Bismillahirrahmanirrahim. I am Muhammad Dalal. And today the topic of my presentation is metastatic hormone refractory prostate cancer or castration-resistant prostate cancer. For presentation, we will first go through anatomy of prostate because this is then we will go to introduction, then symptoms of prostatic carcinoma, then etiology and risk factors of prostatic carcinoma, incidence, mortality, what are male sex hormones, how stimulation hormones, type of hormonal therapy for prostatic carcinoma, how hormonal therapy treats prostatic carcinoma, evaluation of hormonal therapy for prostatic carcinoma, and castration-resistant prostate cancer, mechanism of development of castration-resistant prostate cancer, metastasis of castration-resistant prostate cancer, management of castrate-resistant prostate cancer, and what are EGOT performance status and American Urological Association guidelines about the castration-resistant prostate cancer.
Kindly अपने mic mute कीजिए please. Dr. Shirshak.
Prostate is a fibromuscular and glandular organ lying just inferior to the bladder. Normal prostate weighs about 20 grams and contains posterior urethra. According to classification of lobes, prostate is consist of 5 lobes: anterior, posterior, median, right, and right lateral and left lateral. This is the anatomy of the prostate in which we have demonstrated the lobes of prostatic gland. One is the sagittal section and the second is the transverse section. Then prostate is divided into 4 zones: peripheral zone, central zone, transitional zone, and anterior fibromuscular zone. These are the division of zones which have transitional zone is contributing about 20% of cancer, central zone is contributing about 5% of cancer, and peripheral zone is contributing about 75% of cancer. Prostate consists of a thin fibrous tissue and which are circulatory oriented smooth muscle fibers and collagenous tissue that surround the urethra. Deep in this layer lies the prostatic stroma composed of connective tissues and smooth muscle fibers and which are related to the epithelial plane. Just beneath the transition epithelium of the prostatic urethra lies the peritoneal plane. Arterial supply is from the epiduralizal, internal portal, and middle rectal artery. Veins from the prostate drain into the pre-prostatic plexus, which has connection with the deep dorsal vein of the veins in the internal iliac vein. Prostate can receive rich innervation from the sympathetic and parasympathetic nerve of the inferior hypoglossal gastric plexus. Lymphatics from the prostate drain into the internal iliac, sacral, vesical, and external iliac lymph nodes. In this diagram, they are shown that the prostatic lymph goes to which node. Prostate cancer affects the prostate gland. The gland that produces some of the fluid in semen and plays a role in urine control in men. Second most common cancer and fifth leading cause of cancer mortality in men. Castrate-resistant prostate cancer is disease progression despite androgen deprivation therapy and may present as one or any combination of a continuous rise in serum levels of prostate-specific antigen, progression of pre-existing disease, or appearance of new metastasis. Advanced prostatic carcinoma, previously called as hormone-resistant prostatic carcinoma and androgen-insensitive prostatic carcinoma, is now named more precisely as castration-resistant prostate carcinoma, as it includes endocrine and paracrine androgen production, which is main cause of resistance of prostate cancer cells to testosterone suppression therapy. Castrate-resistant prostate cancer is a spectrum of disease ranging from elevated prostate-specific antigen levels without metastasis of symptoms to metastasis despite androgen deprivation therapy. Bone metastasis occur in 80% of men with castrate-resistant prostate cancer and can produce significant morbidity, including pain, pathologic fracture, spinal cord compression, and bone marrow failure.
Now, just a moment. Just a moment. Go back to the last slide, previous slide, this one. You see, and this was a question which was again asked by you to me, that is there a difference between castration-resistant prostate cancer and hormone-resistant prostate cancer? You see, uh, in the next slide, you have pointed out that now the newer term is CRPC rather than HRPC. Uh, in the West, there are certain groups which are known as patient advocacy groups. Now, patient advocacy groups are those people who actually want to advocate the rights of the patients in societies which are run by medical personnel. For instance, if you are in England, so there are certain societies and associations which deal with cancer patients. For instance, Cancer Research UK, known as CRUK. And similarly, if you go to America, there are other organizations like AUA. And whenever there is a discussion on any pathology, there are certain questions which are raised from the angle of patients' rights. And there are certain people who are actually from the community, and they are the lawyers or otherwise. They know the subject and they know the implications of surgery, but they also want to protect the rights of the patients. So whenever this term castrate resistant or simply the word castrate comes up, then there was a notion in American Urological Association that this actually is a violation of privacy. This is something which is related, and whenever this term is being read or it is being written, it always gives sort of a signal to imagination of something called testis, something called scrotum, and these are the private parts. So they have to be discussed not as a journal sort of a thing, but it has to be discussed scientifically. So what they think that this is a violation of the rights of the patient, it should not be written like this. It denotes something of a bad taste. So if there is a better term, then it should be used. And the better term is again that term which was previously in use. So now the fashion is that we are using HRPC rather than CRPC. So that is my take on the subject or on this issue.
Okay.
Yes, please.
Symptom of prostatic carcinoma. Symptoms during the early stages of prostatic cancer are difficulty starting to urinate, emptying bladder, a weak flow when one urinates, a feeling that bladder hasn't emptied properly, struggling urine after urinating, needing to urinate more often than usual, especially at night. A sudden need to urinate, patient may sometimes take urine before he gets to the toilet. Symptoms during the advanced stage, back pain, head pain, or pelvis pain, problems getting or keeping an erection, blood in the urine or semen, unexplained weight loss. Etiology and risk factors. The etiology of prostate cancer is the subject of numerous studies and remains largely unknown compared to other common cancers. The well-established prostate cancer risk factors are advanced age, ethnicity, genetic factors, and family history. Factors recognized as contributors to risk of prostatic carcinoma include diet, which include increased consumption of saturated animal fat and red meat, lower intake of fruits, vegetables, vitamins, and coffee, obesity and physical inactivity, inflammation, hyperglycemia, environmental exposure to chemicals or ionizing radiation, medication and infections, and sexual activity. Pathology. 95% of prostate cancers are radiocarcinomas, which are developing in the SIUT prostate cancer, prostatic duct. And so there are certain rare histopathological type of prostate carcinoma which contributes to about 5% of patients. They include small cell carcinoma, mucinous carcinoma, endometrioid cancer, transitional cell cancer, squamous cell carcinoma, basal cell carcinoma, adenoid cystic carcinoma, seminal cell carcinoma, and neuroendocrine cancer. Pathogenesis. In the first picture, the normal prostatic histology is shown. In the second, they are shown that stress has inflammation and mental and still proliferation molecular changes which are EST1, down regulation of NKX3, 1 billion and CKL1, which the progression which we see the renal cell hyperproliferation, telomerase shortening, and the molecular changes occurs are ETS transcription factor, dysregulation, NKX3 1 loss, SPOP mutation, DMPRSS2, TRD fusion. And the last here, last basal epithelia, breast membrane breakdown, immune cell infiltration, molecular changes are telomerase activation, PTM deletion, and RB1. Epidemiology. Prostate cancer is the second most frequent malignancy after lung cancer in men worldwide, counting about 1,76,106 new cases and causing 3,58,989 deaths, which are 3.8% of all deaths caused by cancer in men in 2018. Prostate cancer may be asymptomatic at the early stage and often has an enduring course that may require only active surveillance. The incidence and mortality of prostate cancer worldwide correlate with increasing age, with the average age at the time of diagnosis being 66. Incidence. The incidence rate of prostate cancer varies across the region and population. Prostate cancer incidence rates are highly variable worldwide. The age standardized rate was highest in Oceania, 79.1 per 1 lakh people, and North America, 73.7 per lakh people, followed by Europe, 62.1 per lakh people. Conversely, Africa and Asia have incidence rates that are lower than those from developed countries, which are 26.6 and 11.5 respectively. Prostate cancer incidence increases with age, although only 1 in 350 men under the age of 50 years will be diagnosed with prostate cancer. The incidence rate increases up to 1 in every 52 men per age is 50 to 59 years. The incidence rate is nearly 60% in men over the age of 65 years. The reason for this difference among the countries is not entirely clear. The worldwide variation in prostate cancer incidence might be attributed to PSA testing. For example, in Europe, prostate cancer is the most frequently diagnosed cancer among men, accounting for 24% of all new cases in 2018, with around 450,000 new prostate cancer cases estimated in 2018. While in the USA, prostate cancer is the second most common cancer, accounting for 9.5% of all new cancer cases. 1,64,690 new cases of prostate cancer registered in 2018. According to recently conducted research studies, around 40% of the prostate cancer cases in the USA and Europe overdiagnosis through extensive PSA testing. These are estimated number of incident cases from 2018 to 2040 prostate cancer in males of all ages. Mortality. International mortality rates of prostate cancer vary considerably worldwide. In 2018, the highest mortality rates were recorded in Central America, 10.7 per 1 lakh people, followed by Australia and New Zealand. The lowest rate was reported in the countries of Asia, South Central 3.3, Eastern 4.7, and Southeastern 5.4 per 1 lakh people, and Northern America, Africa 5.8 per 1 lakh people. One third of the deaths for prostate cancer occurred in Asia, 33%, followed by Europe, 29%. The mortality rate of prostate cancer rises with age, and almost 55% of all deaths occurs after 65 years of age. These are the estimated age standardized incidence and mortality rates worldwide in 2018 of prostate in males of all ages. Now we come to the topic of hormonal therapy. First, we will learn about what are male sex hormones.
If you go back to the, Jalal, if you go back to the last slide. Yes. For for everybody to see here in this slide is two things. One is the incidence of prostate cancer, and the other thing is at which age this prostate cancer is actually occurring. There has a very wide difference between the incidence rate of prostate cancer in the West as compared to Africa and Asia. Again, it's the same thing. The more you test, the more you get. Since we do not have that kind of capacity here in Asia, particularly in Southeast Asia, and also in Africa, of doing PSA as a screening tool of everybody beyond the age of 50, we are not getting the kind of prostate cancer estimates as the West is having. For instance, in America, if you are a male person and you want your social security as well as your insurance to be renewed every year, then you have to go through a procedure. You have to go through some mandatory tests, and one of them is PSA. So they get to know their patient very early. They get to know those estimates, for instance, PSA velocity. So every year if PSA is being done, then the change in PSA per year can easily be calculated. Now what we have in Pakistan is no discipline at all. Since our healthcare is not geared or actually directed towards something proactively, then we are always sitting in our clinics, in our hospitals, waiting for somebody to turn up with some kind of symptoms, which might be early symptoms or which might be a late symptom, and then we'll see what we have to do about it. So in our case, what happens is somebody has to come to us, and then what we do is we then address the problem. In the West, what they do is they go to the patient themselves. They just look into the problems of the patients, and then they go solving the problem. So it is a different kind of a scenario as we take any disease estimate of the West as compared to the East. It's a different philosophy, it's a different mechanism. So that's why there is a difference in estimates and in incidence rates. Yes, please continue.
Thanks. Hormone substances made by glands in the body that function as chemical signals. They affect the actions of cells and tissue at various locations in the body, often reaching their targets by traveling through the bloodstream. Androgens, which are male sex hormones, are a class of hormones that control the development and maintenance of male characteristics. Testosterone and dihydrotestosterone are the most abundant androgens in men. Almost all testosterone is produced in the testicles. A small amount is produced by the adrenal glands. In addition, some prostate cancer cells acquire the ability to make testosterone from cholesterol. How do hormones stimulate the growth of prostate cancer? Androgens are required as reproductive system that helps. Androgens are also necessary for prostate cancer to grow. Androgens promote the growth of both normal and cancerous prostate cells by binding to and activating the androgen receptor, a protein that is expressed in prostate cells. Once activated, the androgen receptor stimulates the expression of specific genes that cause prostate cells to grow. Earlier in their development, prostate cancer needs relatively high levels of androgens to grow. Such prostate cancers are called castration sensitive, androgen dependent, or androgen sensitive because treatments that decrease androgen levels or block androgen activity can inhibit their growth. Prostate prostate cancer treated with drugs or surgery that block androgens eventually become castration or castrate resistant, which means that they can continue to grow even when androgen levels in the body are extremely low or undetectable. In the past, these tumors were also called hormone resistant, androgen independent, or hormone refractory. However, these terms are rarely used now because tumors that have become castration resistant may respond to one or more of the newer anti-androgen hormones. What type of hormone therapy are used in prostate cancer? Hormone therapy for prostate cancer can block the production or use of androgens. Currently available treatments can do so in several ways. Reducing androgen production by the testicles, blocking the action of androgens throughout the body, block androgen production synthesis throughout the body. These are four general forms of androgen deprivation therapy. Number first is ablation of the androgen source, which is SIUT or castration. Inhibition of luteinizing hormone, releasing hormone, or luteinizing hormone. These are diethyl stilbestrol, leuprolide, corcerelin, triptorelin, estrelin, cetrorelix, and other relics. Inhibition of androgen synthesis, aminoglutamide, ketoconazole. Anti-androgens, which contains serotonin, acetate, glutamide, and glutamide. This is the schematic diagram which shows how the hypothalamus and pituitary release gonadotropin-releasing hormone and corticosteroid-releasing hormone, and their effects on the adrenal gland and the testicles, which eventually the testosterone and androstenedione acts on the prostate cells in the produces cell. The androgen signaling excess and its inhibitors. Testicular androgen synthesis is regulated by the gonadotropin releasing hormone, luteinizing hormone axis. Whereas adrenal androgen synthesis is regulated by the corticotropin releasing hormone, adrenocorticotropic hormone axis. Gonadotropin releasing hormone agonists and corticosteroids inhibit stimulation of the testes and adrenals respectively. Abiraterone inhibits CYP17, a critical enzyme in androgen synthesis. Beta-glutamide, glutamide, and nilutamide competitively inhibit the binding of androgens to androgen receptors. Enzalutamide also blocks the translocation of the ligand-bound androgen receptor complex to the nucleus and form from binding to DNA. How is hormone therapy used to treat prostate cancer? Hormone therapy may be used in several ways to treat prostate cancer, including early stage prostate cancer with an intermediate or high risk of recurrence. Men with early stage prostate cancer that has an intermediate or high risk of recurrence often receive hormone therapy before, during, and after radiation therapy. They may receive hormone therapy after prostatectomy surgery to remove the prostate gland. Relapsed or recurrent prostate cancer. Hormone therapy used along is the standard treatment for men who have prostate cancer recurrence as documented by CT, MRI, or bone scan after treatment with radiation therapy or prostatectomy. Therapy is sometimes recommended for men who have a biochemical recurrence, which is a rise in prostate-specific antigen levels following primary local treatment with surgery or radiation, especially if the prostate-specific antigen levels doubles in fewer than 3 months and the cancer has not spread. Third one is the advanced or metastatic prostate cancer. Hormone therapy used alone is the standard treatment for men who are found to have metastatic disease. For example, disease that has spread to other parts of the body when their prostate cancer is first diagnosed. Variation of symptoms. Hormone therapy is sometimes used alone for variation or prevention of local symptoms in men with localized prostate cancer who are not candidates for surgery or radiation therapy. Such men include those with a limited life expectancy, those with locally advanced tumors, and those with other serious health conditions.
You
Now,
got
how will I know that my
Jalal.
hormone therapy is working?
Jalal, excuse
Doctor,
just a minute. You go back to the slide, previous slide, and then one previous one, one back. That's it. Biochemical recurrence. No, the other one. One forward. This one. This one. That. One back. Yes, this one. You see the concept of biochemical recurrence. It is very interesting. Somebody has asked me, one of our students, sir, 1 year back, we didn't see any patient with biochemical recurrence in our setup. So my answer was, you see, when you do radical prostatectomy, then there will be a concept of biochemical recurrence. The explanation for it is, whenever there is a patient with organ-confined tumor, if you want to treat that person with a definitive approach, then the treatment of the best option is radical prostatectomy. Now, what happens to the PSA when you do radical prostatectomy? The PSA should go down to 0. Now, that is the ideal, and it happens. If your selection process is good, if you have selected your case according to the stage, and the stage is that it is organ confined, then the PSA must go to 0. And it is not only 0, it is 0.000, 3 decimal places. Now what you do, you want to follow your patient. After every 2 to 3 months, you do PSA. There will be a point after maybe 6 months down the line, or maybe 1 year down the line, when the PSA starts rising. And this PSA in some of the patients, not at all, in some of the patients they start rising, but then they start rising from the third place of the decimal, meaning to say 0.001. So this is the third decimal place increment in PSA after touching to 0 level. Now this is biochemical recurrence, but whether it should be acted upon, you should do something for this smaller increment of PSA or not, that is a subject of debate, and also some needs a little bit of thinking. What the current guidelines are and what we do practice here, we always try to check PSA, but we don't act upon when it is at the level of the third decimal place. But when it jumps on to the second decimal place, the example is 0.02. So now there is a change in the second decimal place. If that happens, then that is an indication of doing again restaging plus minus application of external beam radiation therapy. So you see, we have gone on to the level of fine-tuning of following our patients who have been through radical prostatectomy. So if your center or if your hospital is in the practice of doing radical prostatectomy too often, then you will see these patients of biochemical recurrence. Otherwise, you won't see a patient with biochemical recurrence. So that is my take on this subject. We'll see when we talk about the subject of prostate cancer in more details in terms of therapy and management. And we also discuss amongst you how to act upon, at which point, what should be done. We have got a lot of imaging techniques available with us. How to use them judiciously, that is something which needs a lot of understanding of what's happening. Otherwise, if you invest a lot without any cost-effective approach, then it will always be a lot of burden on the system, whether it is the patient who is paying for all the tests, or it is something which is being paid by the hospital or the institution. So we'll see how it happens and at which point one should act correctly, scientifically. Yes, please proceed.
Thanks. how will I know that my hormone therapy is working? Doctors cannot predict how long hormone therapy will be effective in suppressing the growth of any individual man's prostate cancer. Therefore, men who take hormone therapy for more than a few months are regularly tested to determine the level of prostate-specific antigen in their blood. An increase in prostate-specific antigen level may indicate that a man's cancer has started growing again. A PSA level that continues to increase while hormone therapy is successfully keeping androgen levels extremely low is an indicator that a man's prostate cancer has become resistant to the hormone therapy that is currently being used. Now we come to the topic, what is castration-resistant prostate cancer? Many prostate cancers that initially respond to androgen deprivation therapy, which are hormonal therapy with the luteinizing hormone, releasing hormone antagonists, luteinizing RRDF, eventually start responding to this treatment. Such cancers are referred to as castration-resistant, castrate-resistant, or hormone-refractory prostate cancer. Hormone refractory prostate cancer are able to grow in the presence of much lower levels of androgens than hormone sensitive prostate cancer. Mechanism of castration resistance or hormone refractory prostate cancer. Several potential mechanisms may allow prostate cancer cells to grow even when androgen levels are very low. These include increased production of androgen receptor molecules within the tumor cells, either through an increase in the expression of the androgen receptor gene or an increase in the number of copies of the androgen receptor gene per cell. A change in the androgen receptor gene such that it produces a more active protein. Changes in the activities of proteins that help control the function of the androgen receptor. And cancer growth through mechanisms that don't involve the androgen receptor. Metastasis to other organs. Castration-resistant or hormone refractory prostate cancer predominantly spreads to bones. It means that bones are mostly metastasized. The site in bone includes iliac crest, sacrum wings, L1 with 5, 8, bell vertebra, ribs, menogram, humeral heads, and femoral neck. Now we come to the management of metastatic castration-resistant or hormone refractory prostate cancer. Castration-resistant prostate cancer is a form of advanced prostate cancer that is resistant to medical or surgical treatments to lower testosterone levels and has spread to other parts of the body. Over 80% of men with castrate-resistant prostate cancer will progress to metastatic castrate-resistant prostate cancer, with progression being quite rapid in over half of the patients. Diagnosis of metastatic castrate-resistant prostate cancer. Castrate serum testosterone less than 50 milligram per deciliter or 1.5 nmol per liter plus iron. Biochemical progression, which means 3 consecutive ISIS and PSA 1 week apart, resulting in 50% increase over the nadir. And a PSA more than 2 milligram per ml are radiologic progression, which shows the appearance of new lesions, either 2 or more new bone lesions on bone scale or soft tissue lesions using RECIST. What are the treatment options for castration-resistant prostate cancer? The combination of drugs and other treatments can slow the progression of castrate-resistant prostate cancer, even if it has metastasized. These include new hormone treatments, chemotherapy, immunotherapy, and treating bone tumors. New hormone treatments. 2 relatively new hormone therapies have shown promise for castrate-resistant and metastatic prostate cancer. In clinical trials, men lived longer while taking these drugs, even in men previously treated with chemotherapy. One is abiraterone. This medication is taken in pill form. It blocks the chemical production of testosterone throughout the body. Abiraterone taken with prednisone, a powerful anti-inflammatory medication. Enzalutamide. This medication is also taken as a pill. Enzalutamide prevents androgens from promoting the growth of prostate cancer. Chemotherapy. Some men with castration-resistant prostate cancer are offered chemotherapy drugs if cancer cells directly. Common chemotherapy medication for treating castrate-resistant prostate cancer include docetaxel plus the corticosteroid prednisone, cabazitaxel plus prednisone or metoprolol. Immune therapy. In this approach, WBCs are harvested from the patient and used to create a vaccine unique to that patient. The vaccine is then injected into the bloodstream of the patient to help patient's immune system attack prostate cancer. The anti-cancer vaccine is called SIUT. The therapy requires several separate treatments. Immune therapy for more advanced prostate cancer may help to extend life. Treating bone tumors. Metastatic prostate cancer frequently spreads to the bones. Bone tumors can cause fractures and severe pain. Treatment for bone tumors is palliative. That means it's intended to minimize symptoms rather than to cure the disease. They include external beam radiation. This involves radiation therapy being administered from outside the body. Immunotherapy. This drug helps reduce bone damage caused by prostate cancer. Radium-233, this unique form of radiation therapy is injected into the bloodstream and specifically targets prostate cancer tumors in bone. The radium accumulates in areas of bone where tumors are forming. The effect of the radioactivity acts over a very short distance, killing tumor cells with less damage to nearby healthy bones. Now we come to the American Urological Association guidelines. Prior to this, that we will have a look to the performance status. Grade 0 is fully active, able to carry on all pre-disease performance without restriction. Grade 1 is restricted in physically strenuous activity but ambulatory and able to carry out work of a light or sedentary nature, for example, light housework, office work. Grade 2 is ambulatory and capable of all self-care but unable to carry out any work activities up and above more than 50% of their income. Grade 3 is capable of only limited self-care, confined to bed or chair more than 50% of working hours. Grade 4 is completely disabled, cannot carry on any self-care, totally confined to bed or chair. Grade 5 is dead. Now, some patients are discussed here for the management options. Asymptomatic or minimally symptomatic metastatic castrate-resistant prostate cancer with no prior docetaxel chemotherapy. These patients are characterized as having a rising PSA in the setting of castrate levels of testosterone, documented metastatic disease and radiographic imaging, and no prior treatment with docetaxel chemotherapy for castrate-resistant prostate cancer. The key distinction between this patient and index patient 3 and 4, which is coming in next slides, is symptom status. Specifically, this patient is defined as having no symptoms attributable to his prostate cancer. However, one must consider whether the patient requires regular opioid pain medication for symptoms or to be attributable to documented metastasis to achieve this level of pain control. In general, if patients require regular narcotic medications for pain relief, they are not included in this. The treatment options are clinicians should offer abiraterone plus prednisone, enzalutamide, docetaxel, or cefomelicity to patients with asymptomatic or minimally symptomatic metastatic castrate-resistant prostate cancer with good performance status and no prior docetaxel chemotherapy. Standard evidence level criteria abiraterone plus prednisone and enzalutamide. Clinician may offer first generation anti-androgen therapy, ketoconazole plus steroid or observation to patients with asymptomatic or minimally symptomatic metastatic castrate-resistant prostate cancer with good performance status and no prior chemotherapy who do not want or cannot help one of standard therapy. This is second patient, symptomatic metastatic castrate-resistant prostate cancer with good performance status and no prior chemotherapy. These patients have a rising PSA in the setting of castrate levels of testosterone, documented symptomatic metastatic disease on radiographic imaging, and no prior history of prostatic chemotherapy for prostate cancer. The definition of symptomatic disease warrants additional explanation to contrast with index patient. First, the patient must have symptoms that are clearly attributable to the metastatic disease burden, not any other medical condition. Second, that having pain, the patient should require regular pain medication for symptoms attributable to the augmented metastatic basis in order to achieve acceptable level of pain control. If patients require regular narcotic medication for pain relief, then they are symptomatic from their prostate cancer should be included. The treatment option includes clinicians should offer amitriptyline, prednisone, enzalutamide, or docetaxel to patients with symptomatic metastatic castration-resistant prostate cancer with good performance status and no prior docetaxel chemotherapy. Clinicians may offer ketoconazole, steroid, methylphenidate, radionuclide therapy to treat patients with symptomatic metastatic prostate cancer with good performance status and no prior docetaxel chemotherapy who do not want or cannot use one of the standard therapy. Options include ketoconazole, steroid, and radionuclide therapy. Clinicians should offer radium-2 therapy to patients with symptoms from bone metastasis from metastatic castration-resistant prostate cancer with good performance status and no prior docetaxel chemotherapy and without known visceral disease. Clinicians should not offer treatment with either estramoxetine or cefuroxetine to patients with symptomatic prostatic prostate cancer with good performance status and no prior docetaxel chemotherapy. This patient is symptomatic metastatic castration-resistant prostate cancer with poor performance status and no prior docetaxel chemotherapy. Clinical trials have generally excluded patients with a poor performance status which have ECOG grade 3 to 4 from participation. Thus, most data regarding management of such patients is extrapolated from randomized trials of eligible patients who had a better performance status as well as from some smaller trials in registry. Even a phase 3 clinical trial that was presumptively designed for a population considered unfit for vaccine still only allowed the performance status of ECOG 0 to 1 for treatments with acceptable safety profile for increasing emphasis on a patient's quality of life and concentrate on symptom management. Treatment given in the last months of life may delay access to end of life care, increase cost, and add unnecessary symptom management. Patients with poor performance status ECOG 3 or 4 should not be offered further treatment. Treatment includes injection, and clinicians should offer palliative care to patients with metastatic castration-resistant prostate cancer with poor performance status who receive prior docetaxel chemotherapy. Alternatively, for selected patients, clinicians may offer treatment with amitriptyline plus prednisone, enzalutamide, ketoconazole plus steroid or radionuclide therapy. Clinicians should not offer systemic chemotherapy or immunotherapy to patients with metastatic castration-resistant prostate cancer with poor performance status who receive prior docetaxel therapy. Now we have the guideline statements on bone health non-specific to any one index patient. Several factors conspire to place every patient with metastatic prostate cancer at a higher risk of bone complication. First, the median age of onset of the disease is in the late 60s, meaning that the average patient with metastatic disease may be in the 70s or beyond. Clearly, a population at risk of physiologic age-related decreases in bone mineral density. Secondly, a primary therapeutic intervention in patients with recurrent disease and with intervention therapy associated with progressive loss of bone mineral density. Not infrequently to the point of measurable osteopenia or brain osteoporosis, increasing the patient's fracture risk even in patients with non-metastatic disease. Finally, in patients with advanced disease, bones are the most common site of metastatic disease, with as many as 70% of patients at some point in their course demonstrating evidence of disease in this site. Clinicians for this type of patient, clinicians should offer preventative treatment. For example, supplemental calcium, vitamin D for fractures and skeletal-related events to castration-resistant prostate cancer patients. Clinician may choose either denosumab or urolonic acid when selecting a preventive treatment for skeletal-related events for castration-resistant prostate cancer patients with bony Any question?
Right. Good. Right. So excellent presentation, and it's a uh, difficult topic. Difficult in the sense that prostate cancer has got uh, a lot of things contributing towards its biological behavior, like all cancers in the body. Uh, since it is one of the commonest cancers affecting a male gender, it is second to, I think, the whole series, and after bronchogenic carcinoma, it is on the second position all over the world. But you see, the natural history of prostate cancer is very important to understand. It all starts from one point and then it goes on to the level of hormone resistant prostate cancer. So earlier, this same patient will have a stage when this cancer was actually hormone sensitive. Whenever a cancer is hormone sensitive, it is rather easier to tackle with certain drugs. But what happens with anti-androgen therapy is once those receptors who were actually responding were later becomes non-responders, or in other words, actually when you were inhibiting by certain medications earlier, they become stimulants in the later phase of disease progression. Now, it is very important to understand the whole process from where the prostate cancer starts, that is organ confined, and then it has come down to the level of this stage when you don't have many options left. Not at any point in time, maybe when the prostate cancer is hormone sensitive, you have got metastasis. So metastasis can happen in both the conditions, hormone sensitive or hormone resistant. But then it has to be addressed uh, slightly differently, but with the same manner. For instance, as it has been pointed out in the, I think the second or third last slide, that the person at this uh, time of his life has got very little bone mineral left, maybe osteopenia, and the person is liable to get something which is called fracture, which otherwise might not be because of pathology, which might not be because of metastatic focus in the bone. So these patients are very difficult to deal with in that sense. But the positive message of studying such patients in the last 20 years or so in my lifetime is, in the 90s, when we used to see these patients with the metastasis in the bones, whether they are hormone sensitive or hormone refractory, we are pretty sure that we will not be able to see this patient maybe 1 year's time or at the most 2 years' time. The patient will not live longer. Now, we have got a lot of drugs to play with, and these are all scientific, they have got scientific background. They are not something which might act, which might not act. They have got their own mode of action. And now we have got protocols available to treat such patients having devastating stage like this, hormone refractoriness. So we have gained a lot of ground in the last 20 years. Now there is no cause for negative thinking from the clinical side. Now, as a surgeon, you or as a clinician, you have got a lot of uh, positive signals as far as prostate cancer is concerned. Again, as it goes with any other cancer, the earlier you diagnose, the better will be the result and the better will be the condition of the patient in years to come. The same goes with this cancer also. Yes, Faizan, you want to say something?
Yes, everybody. Sir, I just wanted to ask about the PSA. As far as my knowledge is concerned, the PSA is the basic screening tool we have. So once I was in that OPD where some professor said that TS is not specific nowadays. It can be variable due to age or something else. Can you enlighten us more about this level?
Uh, I can take that statement again with some inverted commas. Yes, it is not something which is very specific. It might not be sensitive, but it is the only thing that is available still now in clinical practice. Uh, Whenever you see a patient having a lower urinary tract symptom complex, then you always start from the angle of whether you are seeing a patient of benign prostatic disease or you are seeing a patient with cancer prostate. Patient with cancer prostate will always have the same kind of symptoms as benign prostatic hyperplasia. Uh, the thing is, if somehow we are able to develop a healthcare system where before having any kind of lower urinary tract symptoms or any bone pain or any symptom related to prostate, we'll be able to pick that person by means of PSA again, then then it will be a game changer. Game changer in the sense that we'll have morbidity and actual mortality reduced to a minimum level. But that is something which might be a wish or a desire in our system. So what we do is whenever somebody comes to me or comes to us in the clinic, I always start my prostate work with PSA because this is the only thing. Whether it is sensitive or it is not sensitive, it's something different. What I do is, or what we should do, is always take that first estimation of PSA and then look into it. Maybe it is within the normal range. The normal range now is slightly different. Earlier it was like 0 to 4 nanogram per ml, no matter in which age group the patient is. Now there is some revision of this concept. The revision is according to the age group. For instance, if you are between the age of 45 and 50, there is a range which is different. If you have got an age between 50 and 60, the range is different. If your patient's age is beyond 60, there is another reference range. So the reference range changes. But for all practical purposes, it is not 4, which is the highest value of the normal range. It is now 2.5. So if you have got a patient who is like 50 years plus, no matter what is the ultimate end of that group or range, maybe it is 80 years, maybe it is 70 years, but if it is beyond 50, then the knowledge that we have today is we take the normal range between 0 to 2.5. Now, what happens if we slightly reduce this upper level of the normal range from 4 to 2.5 is we have got a slightly larger population of suspected prostate cancer patients so that we might be able to do biopsy on them. So the next step of after doing PSA is we go on to do biopsy. Are you listening to me?
Yes.
Okay. So what the next step is, you want to do biopsy. Now, the yield of the biopsy is what we want to know. The biopsy, if it hits a target and it becomes a positive, then it's a news. If it hits a negative focus, then again, you have done your work and the patient is not a cancerous patient. You haven't picked it up. So in order to have a lot of positive biopsies or in order to gain some confidence within the system of picking up patient with prostate cancer more and more, then you have to lower down this normal range of PSA from 4 to 2.5. So that is my take on the subject. And still this is something which is debatable. It is something which is not taken on as such by our pathologists here in Pakistan, in our institute also. They don't want to reduce the normal level from 4 to 2.5. They have got their own reasons, but for all practical purposes, what the uh, the world, in which direction the world is moving, is something of picking the patient early. What they don't want to see are patients who have this kind of problem, HRPC. What they want to see are those patients on whom you can do uh, radical prostatectomy, so that you can do away with the prostate, nip in the bud. That is what we call in English language. So if we come back to your question, whether PSA is the ultimate choice, it might not be the ultimate choice, but it is something which is available, and it is something which can be used judiciously. Uh, there are certain other things. For instance, if you have got prostate volume assessment also, then you can take PSA density. How you do PSA density, how you calculate PSA density, you always um, divide PSA value from the prostate volume. If the value is like 0.14, then 0.15 and beyond, then it is more in the range of having malignancy. If it is between 0.04 to 0.1, then it is something which is benign. So this is how the whole game goes. You can take serial PSA. For instance, you hit one sample, you take one sample of PSA in a patient, and it is like maybe 4, maybe 3.5. You have done your DRE examination, and you think that this prostate is not a cancerous prostate, it is not stony hard, it is something which is firm to soft. What you want to know is maybe after 3 months time, you do PSA and the intention is that the PSA remains at the same point, that is 3.5. So this is known as change in PSA per time. So if there is a change in PSA within 6 months, within 3 months, then this is known as increasing velocity of PSA. So that is how you calculate PSA value. But again, what you want to have are positive biopsies. You want to do biopsy, the next step. So PSA will always guide you to go on to the next step with some confidence. So if your PSA level and PSA estimation is such, then you would go on to the next level, otherwise not.
So, another thing which scares me actually, can this prostatic cancer can mimic like DPH, or we can fail the early detection of it?
Yes.
Like we are.
Yes, because symptoms are the same. You see, whenever prostate enlarges, whether it is a benign enlargement or a prostatic enlargement, again, the symptoms will be a reflection of something on urinary flow rate. So lower urinary tract symptoms will be the same whether you have got a prostate cancer or you have got benign prostatic hyperplasia. So these cases do happen to miss some protocol. If you don't have any doubt at the back of your mind, you won't look for it. Yes, Raf.
So, sir, it is advisable for patient we tell them they do PSA levels yearly or after every 5 years or 3 years, just to see whether or not they are developing, or if there is some chance of prostate cancer developing.
You see, we don't have any guideline for our own population. We don't have any guideline for our region, at least. So there is no such thing here. It depends upon institution to institution, the institutional policy. Our institution policy is we take it as a kind of a semi screening tool. Semi means we have got a prostate clinic, and that prostate clinic actually deals with a lot of things related to prostate, maybe prostatitis, maybe benign prostatic hyperplasia. But one of the objectives of that clinic is to pick up those people who are within the pool of and prostatic enlargement which are termed as having benign prostatic hyperplasia. Somewhere there is someone who is actually within the pool of those patients but is a cancerous patient. So we want to pick up those patients from that clinic, which happens to be a benign prostatic hyperplasia clinic, so that we'll be able to have um, prostate cancer in our oncology clinic. So in that way, we are kind of hunting those patients from the population that comes through our door in that clinic or in any other clinic in OPD 14. Yes, the forum is open for any question, any clarification.
So one more thing.
Yes.
Why haven't we developed or in our region, for instance in India, in Pakistan, why don't we have any guidelines that we see in Europe or like, are there any bureaucratic hurdles or something like that? There are never find any.
I can't, I'm not qualified to answer that question, but you see, every region has got its own baggage. The kind of baggage that we have in our subcontinent is we are not scientifically oriented. And again, same thing, we don't want to discuss as a common group amongst ourselves, so that we'll be able to forge a common front. For instance, on a city level or a provincial level or a country level, we don't have anything of such a sort. We have got societies, for instance, Urological Society of Pakistan and things like that, but they are not inclined to put forward their efforts in that direction. So this is something which is, I think, our character is actually lacking. We don't address these problems as a community, rather. So I can't say much about it, but what we have is we are not proactive. We are always we always react to situations. We always do damage control. What we lack is planning. What we lack is something which is predictable models. What we lack is something called preemptiveness. So these are all things which, when put into practice, is actually a reflection of our own thinking process. We are bad planners, or if you want me to say, no planning at all. We always live like this, or maybe we will be living like this unless and until a generation like yours come up with something, a novel idea of putting yourself, your personal interests slightly at backstage, and put the national interest in front of you. Yes, please.
Sir, SIUT has its own institutional protocols regarding this screening prostate.
Yes, we have. We have not only we have devised, but we keep on changing our protocols according to the need of the time. For instance, for the last maybe 6 months or so, we have changed a lot, changed the practice, changed the complexion of prostate clinic. Now it's a clinic which is a screening clinic. Earlier it was a clinic only to pick up those persons for TURP, for instance, or open prostatectomy. Now this is a clinic, actually, number one objective of that clinic is to pick up those people who are having PSA, who have got PSA velocity, which is on a higher level, and they should have biopsies early. So our rate of doing biopsy has gone up in the past 6 months. Now we have put in protocols of doing repeat biopsies. For instance, there are people who have got high PSA, they have been through biopsy, but the biopsy is negative. What we do is we put these patients on surgical list and do TURP and forget about them. Now what we do is we always keep them under surveillance. If at all we do TURP for prostatic obstruction, for the obstruction of urinary flow, we always keep them under surveillance. We repeat PSA even after TURP and see if the PSA is high or not. If it remains high, then we keep this patient for another biopsy session, maybe in very near future after surgery. So we keep on doing biopsies till such time that we hit a target, because these are the patients who have got very small portion of the prostate which might be less than a centimeter turning into cancer. Now, you see, the process of doing biopsy, it is something of hitting without any direction. These are non-directional biopsies. These are not fusion biopsies. For instance, the whole pear-shaped structure of prostate is randomly divided into segments, and those segments are targeted through a transrectal probe. Even if your biopsy needle is going through a perineum, which is known as transperineal biopsy, the target is actually seen through a transrectal probe. So whether your needle is going through the rectum or it is going through the perineum, the vision is through the rectum. Now, you can visualize the lobes of the prostate and the segments of the prostate randomly and on an imagination level. But anything which is turning into cancer will not be seen on those ultrasound films. So you hit different areas and you take 12 different biopsies. All those biopsies are then read. But there are many different areas within this pear-shaped structure. Between those hitting points, there are certain other points which are left behind. Maybe those points are actually turning into cancer. We don't know. Unless and until we do something called multiparametric MRI and then fuse the MRI picture with the ultrasound picture and guide the needle towards that focus, which are actually being picked up by two different modalities of imaging, then that would be a targeted biopsy. Then that would be a fusion biopsy, and it would have a very high yield of hitting positive areas. Otherwise, we will be missing a lot. Yes, Rafa? No question. Right. So it is a very interesting topic, and it is a topic which is interesting in the sense that we are changing too frequently the protocol of application of knowledge, changing the protocol of doing biopsies, when to do biopsy, how many biopsies should be done. Because whenever you want to do something, you have to take your patients within the discussion. You can't just keep the patient out of the loop, asking them to do or undergo biopsy without telling them the importance of doing repeated biopsies. So if as clinicians, if we are clear in our minds, in our philosophy, why we want to do it, then we'll be able to give confidence to the patient. We'll be able to convince them that this is important, and that is the reason why they should do another biopsy maybe every 3 months or every 6 months. They have to undergo a biopsy. Unless and until your philosophy, your thinking is clear, you will not be able to guide your patient or convince your patient. Yes.
Dr.
Hamza, you want to say something? Ji, Assalamu
Sir, my question is that early stage treatment have more chance of recurrence. Why?
Early treatment? Just repeat.
Early stage treatment have more chance of recurrence.
Recurrence.
Why, sir?
Because of longevity. You see, the longer the patient lives, the higher will be the chance of having cancer progress to later stages. That depends. For instance, if you have got a patient who has an organ confined tumor, and if you do radical prostatectomy, then that radical prostatectomy should have a reflection on post-operative PSA estimation. As we were discussing the concept of biochemical recurrence, it should remain at 0.000 for the rest of his life. That is our wish. But what happens is, maybe 6 months down the line, or maybe 2 years or 1 year down the line, there is a change in biopsy. There is a change in PSA level, and that change actually happens. If it actually happens at the third place of decimal place, then it has got no value. But if that change is at the second decimal place, then it has a value. It has to be addressed. You see, so if you treat the patient in early stage of the disease, you've got to have that patient under surveillance for the rest of his life. You can't say to your patient that since you have done something in the early stage, then the problem is over. The problem is over for many patients, but problem might not be over for a smaller fraction of patients. So for all practical purposes, your patients should be under your surveillance, within your vision, for the next of their maybe 5 years or 10 years down the line, and that is the protocol also. So when we say that if you treat in early stage, there will be higher rate of recurrence, there is no higher rate of recurrence, but this should always be there as something which might happen if you miss your patient during surveillance.
Right. Right.
Right. So any other question? No questions. Right. Okay, so today we have completed our 12th presentation. It was again very commendable on your side, as you have all put forward your best efforts, and we'll summing it up after 2 presentations or 3 presentations, and then um, I will discuss with you something more, and then we go on to the second round presentation. So this is all in the quest of not wasting time. First objective, keeping you within the loop of understanding, discussing urology, as we all want to learn urology, and uh, we have to progress in one direction, and the direction is your residency. So your residency is something which is of paramount importance, and it should not become hazy. So that was the main objective of doing all these presentations and discussing them with you. There is a suggestion. You keep that suggestion with you, and give me your feedback if that suits you. I have discussed this thing yesterday with Noman also. Since this lockdown and this coronavirus contagion, we have changed the complexion of our presentations at SIUT also, for all those who are here in this city, in Karachi. Now we don't have journal clubs and registrar forum in big rooms with all the people sitting in front of the presenter. What we do have is a single presenter on the podium and a single person like me or any other person just listening to that presenter, and we all record that presentation, and that is known as Journal Club 1 and Journal Club 2. We got 2 presentations, one on Wednesday, the other one on Friday. Now every presentation is recorded and uploaded on our YouTube channel. The students, the residents are asked to see that, and then on the following day, for instance, if it is on Wednesday, then on Thursday, we give them 5 MCQs that have to be solved within 12 hours online. So it's a Google form. You just click the right responses or your responses and then submit. After 12 hours, that would go away. You won't be able to go back. So, for instance, tomorrow is Wednesday. There will be a presentation at 9 o'clock. but then there'll be that would be uploaded in the afternoon. On Thursday, all the residents are asked to fill those 5 questions. So if that suits you, we'll include you from Monday next, coming Monday. If it doesn't bother you much, you just think about it and give me the feedback. There is a third activity, and that is a case discussion on every Monday. And that again, that case is put up on the online, and you are asked certain questions again online. So the whole activity is online. So if you want to participate, you want to be included, then that would take up a little bit of your time in addition to what you are doing right now. And from Monday, we'll be having again other presentations also, second round presentations. So think about them, think about these activities, and after say 1 or 2 days, I'll ask you again, probably on Saturday. If you think that it is a good sort of engagement, then I'll include you on that WhatsApp group also. Right? Thank you very much. Khuda Hafiz.